To move on now behind the eyelids to the eye socket or orbit. One of the most important causes of red eye is orbital cellulitis. This is a compartment syndrome of the eye socket, which is bounded by bones on 5 of the 6 sides and anteriorly by the septum of the orbit. Thus, if you get an infection inside the eye socket, all the structures, including the eye itself and the muscles and the optic nerve, can be squeezed and eventually lead to long-term blindness. The presenting features are of severe pain and redness. Often the eye is proptosed and there is restricted movement leading to double vision if the eyelid is not closed over it. The patient is usually severely unwell and has a fever. Treatment is by intravenous antibiotics and sometimes requires drainage of a sinus abscess. Other non-infectious orbital causes of a red eye include acute thyroid eye disease and the very rare situation of a carotico-cavernous fistula. We're now going to go on to probably the most common cause of red eye, and that is conjunctivitis. The conjunctiva is the mucosal lining of the white of the eye and the inside of the eyelids. We can consider the causes in terms of infective, allergic and other inflammatory causes. And we're going to pause briefly on 2 serious causes of conjunctivitis, namely Ophthalmia Neonatorum. But first, let's talk about viral conjunctivitis, because this is by far and away the most common cause of red eye that you're going to encounter in your careers. It's usually due to one of the common cold viruses, such as adenovirus. There will often be a history of coryzal symptoms, and you may be able to palpate for tender pre-auricular lymph nodes. Treatment should be avoided because it is a viral conjunctivitis. It's self-limiting and neither life-threatening nor sight-threatening. Bacterial conjunctivitis can be a bit more serious and is characterized by a rather thick, mucky discharge from the eye, and the eye tends to be redder. Once you've taken a swab to prove the organism responsible, you can then treat it with topical antibiotics such as chloramphenicol or ofloxacin. So the 2 serious causes of conjunctivitis are those developing at birth. Chlamydia and gonococcus are 2 serious conditions because chlamydia can be associated with a pneumonitis at birth, and gonococcus can lead to perforation of the eye. The first is more common in the Western world, the second is more common in sub-Saharan Africa, but both of them need swabbing and treatment. Chlamydia can affect adults, particularly those who are sexually active, and you should consider chlamydial conjunctivitis if a patient presents with a monocular red eye, particularly if you find follicles, that's little bumps on the inside of the lower eyelid. You should take a swab, and if positive, it can be treated with the topical tetracyclines, but possibly more importantly than that, these patients also need to go to the GU clinic. Allergic causes of conjunctivitis are almost as common as viral causes, particularly if there is a history of hay fever. It's treated with antihistamines in the same way that hay fever is treated. A particularly nasty form of allergic conjunctivitis is vernal conjunctivitis. It tends to be worse in spring and early summer and can be associated with these little bumps around the limbus and uncomfortable stringy mucus. At its very worst, it can be associated with these large overgrowths of the B cells in the mucosa of the inside of the upper eyelid, these so-called cobblestones and giant papillae. And they can really cause sight-threatening disease due to the cornea being affected. And you can see here in the bottom left, this cornea is very sick. There's epithelial erosions, which can lead to complete breakdown of the epithelium. This is a shield ulcer and can lead to perforation and long-term scarring with visual impairment. Allergic eye disease, of course, is associated with other signs of atopy, such as eczema. A very nasty form of inflammatory conjunctivitis is the Stevens-Johnson syndrome. This is a basement membrane autoimmune disease, often kicked off by infection or antibiotics. And being a basement membrane disease can affect not only the mucosa, such as on the tongue and the oral cavity, but also the skin. It's associated with a conjunctivitis, and so you should perform a skin survey if you suspect Stevens-Johnson syndrome. Sometimes you can get this very nasty woody discharge, which requires surgical removal. We're moving further back in the eye now. Underneath the conjunctiva is the white of the eye, consisting of the episclera and sclera. And at this point, I want to make it absolutely clear that scleritis is very rare. You may remember that the sclera is the white of the eye, but it is such a tough bit of collagen in the body that is pretty resistant to inflammation and infection, whereas the overlying episclera is quite a common structure of the eye to be inflamed. This is an autoimmune phenomenon and is often focal. It affects part of one eye, and here's a focal episcleritis of the right eye. Here is a nodular episcleritis of the right eye. You see there's a raised nodule. Sometimes it's diffuse, but the eye tends to be pink rather than red. Treatment is usually conservative or with topical non-steroidal anti-inflammatory drugs. By contrast, the very rare phenomenon of scleritis is an exquisitely uncomfortable condition. The eye is a really brawny, violaceous red. It doesn't blanch when you apply phenylephrine drops, and that will distinguish it, if you really need to, from episcleritis. It needs to be treated with topical and usually oral steroids, and is often associated with systemic disease such as rheumatoid arthritis. When scleritis takes hold in the setting of rheumatoid arthritis, it can lead to complications including necrosis, and you see here an avascular part of the sclera, and sometimes thinning and perforation, the so-called scleromalacia perforans, and is a reminder that we need to keep both the local and systemic diseases under control with topical and systemic anti-inflammatory and disease-modifying agents.